Hi. I'm Diana Artene. I'm a dietitian, and I came today to speak with you about lymphedema and how can we prevent it, because nutrition is part of the supportive care in the breast cancer treatment, and what we really want is not just the patient to survive, but to actually have a good quality of life. And lymphedema can prevent good quality of life. It can decrease the quality of life either by the fact that it impairs body image, either because it can associate chronic pain, all sorts of sensitivity modifications, and depression, anxiety, and so on. So the question today is, how can we prevent it? How I see it is, the first step in lymphedema prevention is screening. Because if we detect breast cancer earlier, we can treat it with fewer side effects treatment, and lymphedema might not be so much of an issue. The problem is that even in countries with national screening programs, many women do not do the screening either when they are invited or educated. So breast cancer secondary lymphedema usually starts with the breast surgeon that has to thoroughly evaluate the fact that the axillary dissection is or is not necessary. This curative treatment associating a lymphedema risk of 40%. But we have the patient, and we think that all the lymphedema discussion should, let's say, be about axillary dissection prevention. But it's not that simple, as lymphedema risk can also arise secondary to sentinel lymph node biopsy, to radiotherapy, chemotherapy. Genetics and anatomic factors can associate an innate increase of lymphedema, and seroma can double the risk of lymphedema independent of axillary dissection. Also, the decreased shoulder mobility in patients who don't do the proper physical therapy needed to recover all the shoulder mobility can have an increased lymphedema risk. And also, local infections and comorbidities like hypertension can associate a higher risk of lymphedema in breast cancer patients. But although most lymphedema prevention starts with breast cancer patients and it can be discussed in the multidisciplinary team, most lymphedema specialists are agreeing with the fact that 90% of prevention lies in patients' lifestyle. And what we can do as dietitians to prevent or to decrease the risk of lymphedema is to counteract obesity. And obesity can increase the lymphedema risk in two ways. First, obesity decreases the treatment efficacy and associates more lymphedema-related side effects. Obese patients have lower chances of obtaining pathologic complete response, thus to avoid axillary dissection, and also obesity increases the risk of chronic pain and of other complications associated with breast surgery. And also, obesity is associated with a higher risk of depression, breast cancer comorbidity that can make the patient take less and less care of herself. And it's for nothing that we tell her to do that, do the other. If she has depression and she doesn't have the proper psychological support, she will not adopt the adequate lifestyle that will lead to a decreased lymphedema risk. And second, local adiposity increases by compressing the lymphatic vessels, increases the risk of lymphedema, and also we know that lymphedema itself increases the deposition of local fat. So it is a positive feedback loop that aggravates while the patient increases in body fat. And I will explain why it is important that we separate total body weight from body composition. Lymphedema, it is related with body composition, not necessarily only with the total body weight of the patient. And we know that fat loss decreases lymphedema even in affected patients, but it has to be fat loss. We cannot decrease the risk by starvation diet. And although these are like an epidemic today, everyone, let's say, advising the patient to eat less or to try to cut weight by any means necessary, either for surgery or either just because they know that obesity increases morbidity and mortality in breast cancer patients. If we obtain this weight loss by eating too little, the patient will lose muscle, not fat, and this will lead to just a movement of fat from the fat tissue in the muscle cells. And the ectopically deposited fat in the muscle cells will make these cells less and less able to contract, and the consequence will be a metabolic decrease. And how can we all maintain metabolism? This is very important when we are talking about lymphedema, because we have a daily muscle protein balance that we all have to maintain. Surgeons and breast cancer patients too, because if we don't understand that biology applies to all, we can just say to the patient, you go eat less, you lose weight because I want you to lose weight, but the overall impact on lymphedema risk will not be attained. So we have on one side the protein muscle synthesis that is influenced by the protein intake of the patient and by the patient's physical activity level. And on the other side, we have the muscle protein breakdown that is increased during breast cancer treatment. And if we have a higher protein breakdown because of the treatment, and if we don't counteract this with a higher protein intake and with a higher activity level, then what we will have will be a metabolic decrease that is sustained by sarcopenia. And in patients who do not overeat, this leads to increased adiposity, and in patients with an excessive carbohydrate intake, then this leads to increased adiposity and weight gain. And this increased adiposity, as I said, and as studies show, increased lymphedema risk independent of axillary dissection. Of course, axillary dissection is important, but if we have increased adiposity, then we will have a higher risk. So, the message was that sarcopenia can affect normal weight people and obese and overweight people. So if you look at the normal weight patients and you don't know the body composition, you can assume that the risk is lower just because she's not obese or she's not overweight. But if we have a high adiposity, that patient can develop lymphedema just because we address it the wrong way. And the problem is that, as I said, we have protein breakdown and we have protein synthesis. And if we have a patient with a low protein intake, with a low physical activity that are not enough to counteract the higher protein breakdown induced by the treatment, that this patient will have more negative outcomes. And this is more often in patients with all sorts of Facebook-educated nutritional beliefs. Patients that think that animal protein causes cancer or all sorts of other things they do. And despite this belief, we have many studies proving that even the evil milk protein are not carcinogenic, and that eating unprocessed red or white meat does not cause or is not in any way associated with breast cancer. And insufficient protein intake is aggravating the side effects of breast cancer treatment, and this is why during the treatment, as dietitians, we ask the patient during chemotherapy and radiotherapy to eat more proteins, to have less side effects. Also, during, before and after surgery, we ask the patient to eat more proteins to recover faster. And during anti-estrogenic treatment, we ask the patients to eat more protein to prevent osteosarcopenia. But it is a higher than normal daily intake. I mean, we recommend the patient to eat more proteins as part of a dietary style similar to the Mediterranean diet. It is not about the ketogenic diet, and although we all the current scientific literature contraindicate this type of diet. Many patients choose to fast for days or for hours or go and eat no more carbohydrates, and this can lead to ketones appearance, and these ketones sustain recurrence and metastasis, increased tumor aggressivity, treatment resistance, and autophagy-induced areas of necrosis. And this is why the general recommendation is that the ketogenic diet is completely contraindicated in any cancer patients, no matter the stage. All we want is the patient to have complete equal meals built on all categories of food, with a bit of a higher focus on consuming foods that are naturally high in proteins at each meal. But, as I said, we have protein synthesis that is sustained both by the fact that, by the patient's protein intake and by physical activity. And this can be a problem because physical inactivity or the avoidance of physical activity is still recommended by some surgeons, either based on their clinical practice, either based on the studies, old studies that questions the safety of practicing physical exercise after axillary dissection. But even without this old recommendation, patients with chronic pain usually protect their arm and they have asymmetrical biomechanics of the entire thorax that can gradually affect the other shoulder joint too. And this over the long term can increase the lymphedema risk. And we have many studies proving that the symmetrical use of both arms is during household activities or during sports activities like swimming, yoga, pilates, aerobic exercises practiced symmetrically with both arms without protecting the arm on the side of the breast surgery, or even resistance training supervised by a physical therapist with free weights or dumbbells or body weight does not increase, does not generate, and does not aggravate lymphedema. Physical exercise is safe in breast cancer patients with or without axillary dissection, and we need to know the fact that the effect is a decreased lymphedema risk, not an increased one. But even though we have the scientific data to support the fact that losing fat through the proper eating and through the proper physical activity, the problem is compliance, patient's compliance. And in the Oncology Institute in Bucharest, I evaluated the patient-related factors and the treatment-related factors that influence the efficacy of the nutritional recommendation necessary to counteract sarcopenic obesity in more than 1,000 breast cancer patients. And what we found is that about the treatment-related factors, there was no influence either by chemotherapy, radiotherapy, breast surgeries, or salpingo-oophorectomy. The only influence was in patients on tamoxifen. They had a bit lower, our recommendation had a bit lower efficacy, but this was mainly related to the age, and I will show you this in the next slide. And also it was a difference between tamoxifen and aromatase inhibitors, and the patients on letrozole lost the most weight and they obtained a higher visceral fat loss. But related to the lymphedema risk, it is important the local fat deposited in the arm at risk, not visceral fat loss. So all this is not related to the type of the antiestrogenic treatment is not related to the risk of lymphedema. About the patient-related factors, what we found is that efficacy of our nutritional recommendation applied long-term was influenced by the fact that many patients developed de novo thyroid disease after breast cancer diagnosis because they adhere to all sorts of nutritional recommendation high in nitrates, and this can inhibit the proper function of the thyroid gland. And also many, because of the stress, developed sleep disturbances. Both of these associate an increased sarcopenia, and we have these patients losing the same amount of weight, total weight, but this weight was muscle loss, not fat loss, despite applying the same nutritional recommendation. Another problem was with patients on statins and in patients on depression. And although we know that having a cardiovascular disease does not impair fat loss, what we saw is that patient on, and it's very small here, you cannot really read it, but it's patient on anastrozole and patient on exemestane with co-administration of statins had the lowest results. And this was very important because if you understand that both anastrozole and exemestane and statins have a myotoxicity side effect, then maybe we should not recommend them together. And the third thing we observed, and this may be explained also why the patient on tamoxifen had lower results, is that our younger patients had the lowest compliance and the worst results. So I would like to end in a note to like a personal philosophy. These breast cancer patients are people just like us, and when we evaluate any compliance to any nutritional recommendation we give to them, we always must remember that anything that can influence any person's compliance to a recommendation will be valid in their case too. And the most important obesity-related factor that influence efficacy is leptin resistance. And what I want you to know about leptin resistance is just this. Eating behavior can be influenced by many factors in general, but it is influenced in specifically by two hormones. And we have ghrelin, the appetite hormone, and we have leptin, the satiety hormone. And either if we don't know, either if we just tend to forget, the satiety hormone is secreted by fat. And the more fat you have, the more satiety you have. But the problem is these higher and higher levels make the hypothalamus to be deaf to leptin actions. So when you have higher levels of satiety hormone, you feel like eating more often just because you have more adiposity. And please mind that it is about adiposity, is not about the total body weight. People with body weight, with all sorts of body weights and shapes and sizes, with higher adiposity, have more appetite. They want to eat more than a person with normal adiposity. What we know by now is that normal levels adiposity sustain easier to control eating behavior. Higher levels of adiposity sustain harder to control eating behavior. And this is how leptin resistance diminishes long-term compliance to weight loss nutritional recommendation. And if we have a patient that doesn't have the proper psychological support with the eating behavior disturbed by leptin resistance, then this patient would not be able to apply our recommendation long-term. And my message for today is that although breast cancer secondary lymphedema prevention starts with the breast surgeon, preventing lymphedema is really a teamwork. And we actually have the physicians, which is normal, we have the breast nurses, and we have the physical therapists that must do the early physical therapy, and we also have the psychologist and the dietitian. And it is important to know that when it comes to lymphedema prevention, long-term lymphedema prevention, let's say doing manual lymphatic drainage, wearing the compression garment, preventing local infection, and even lymphatic microsurgery, all are less efficient in sarcopenic patients. Thank you.